Hi, everyone, and thank you for tuning in to episode 11 of the Real Heroes Don't Wear Capes podcast. I'm Stephanie Carter here with Crystal Sutherland and Michael Weens from the HS Heroes team. And today we're joined by Dr. Chris Keeling. Dr. Keeling, if you could please introduce yourself.
Hi, my name's Chris. I'm a dermatologist. I practice in Edmonton, Alberta. Did my dermatology training in Edmonton, but finished my training in Montreal at McGill doing a surgical fellowship. And 50% of my practice is oncology, doing cutaneous skin cancer surgeries. Before that, I was in Halifax, and my alma mater for medicine was at Dalhousie. Before that, I was all over the place. I did a master's in Aberdeen, Scotland. I did a PhD work in Connecticut. I've studied at La Sapienza in Rome, studied in Wales, and did a year in Maine, Orono, Maine, as an undergrad. I have 3 kids and a happy general dermatology practice in Windermere, Edmonton. And outside of kids and work, my only other interest is acquiring my private pilot license.
So we were just talking about it before we started filming, but Dr. Keeling is going to be flying into northern communities to help treat patients there who don't have access to healthcare. But I think we'll just jump in with what first inspired you to choose dermatology as a specialty?
Yeah, interesting. Because of my graduate school work, I was a parasitologist. I studied organisms that live off of other organisms, and I was quite familiar with the human parasites. And I thought I was going to do infectious disease. When I started at Dal, I did a 1-year elective in infectious disease, and I wasn't inspired in the same way as I became inspired with dermatology. So I asked an uncle, what's the area of medicine that you don't need to know the kidney, the lungs, the liver, how they all function to start learning early in your medical school training? And he said, dermatology. Nobody knows it when they begin. Nobody knows it when they end. And so I got inspired and got the syllabus and took a bunch of pictures and made a little lab manual with a slideshow for everybody, and did an elective with a dermatologist in New Brunswick and fell in love with dermatology. It was unexpected, and I've never looked back since. It was a true passion. I'm a visual type of person. When I did my graduate school work, you identified organisms by their features, their characteristics. And in dermatology, it's all about what you see. The story is interesting, but it rarely directs you to the diagnosis. It's about seeing features that you're trained to see and turning that into a diagnosis and a treatment plan.
So when you were first learning about dermatology conditions, did you see HS or did you learn anything about it in school or during your early years?
In medical school, I'd never even heard of the condition. I mean, it was in the textbooks, but a small paragraph, maybe a photograph. The bigger 4-volume textbooks certainly have some information about it, but not enough to consider it anything other than an orphan condition, rare condition that you might or might not see. During my residency, I don't recall a particular case, and I don't remember a longitudinal case where you followed that patient for any length of time. And even in my surgical fellowship in Montreal, I was never introduced that condition as a surgical dermatologist that there might be a role. And for my first 5 years of dermatology in Edmonton, 2006 to 2010, 11, I might have had 4 or 5 patients with the condition, and like many doctors, didn't offer much hope or a solution. I really was trained to believe it was an infection, and you used antibiotics to try to kill the bugs. And we've come a long way since then.
So what stands out for you now as something you wish that they had taught you early on when you were in school that you wish all med students, including family doctors and all specialties, would know about HS?
Well, first, that it's not rare. It's not an orphan condition. There's probably as many patients with some degree of HS as there are patients with some degree of psoriasis or some degree of atopic dermatitis or eczema. And that continues to be a surprise. When I first started seeing patients with HS with some knowledge, I couldn't believe how many people had this. And more importantly, how long it had taken them after presentation to get to a specialist who knew what was going on, and how poorly they had been managed and treated from our general practice, emergency physicians, and frankly, our dermatology community.
Would you be able to estimate in a month how many HS patients you see?
I can, yeah. I see 2 new patients every day, 5 days a week.
Oh,
I
wow. Okay.
do 2 surgical patients. I might do 1 to 5 sites on a patient every day. So yeah, in the span of a month, if I work 20 days, I probably will see 40 patients new.
Wow.
And follow-up patients are, of course, coming in on an ad hoc basis if they have acute lesions. But I have at least 2 cases of surgery in the afternoon after my surgery clinic in the morning for skin cancer is over. I will see probably 2 patients for some sort of surgical intervention.
Oh, wow. Okay.
I was just gonna say, even today, not all dermatologists are well informed about HS. I just had a friend who got an HS diagnosis in her 30s, and it takes a lot of time for us to get in to see a dermatologist sometimes because there's a huge waiting list. So she tried to see another dermatologist kind of in the interim to see if there was some smaller management that could happen, and he didn't know what it was. He pulled out a textbook to flip through pictures and then told her that it could be furuncles, carbuncles, or HS, and then told her there was no treatment available and she was going to have to just live with it. And I was just like, it was infuriating because we know there's so much treatment available now. So I made her go to my dermatologist, but there's still, derms everywhere who aren't familiar with HS and HS treatment, even though there's so much now.
In the last 5 years, as I've become more involved with the HS community, I've given a talk to dermatologists in Vancouver Island, Vancouver, in Edmonton, Calgary, Winnipeg, Saskatoon, Regina, Toronto. I've gone to some meetings, Montreal, Fredericton, Halifax, and Charlottetown. The only province I haven't visited so far is Newfoundland. And I think in general, the knowledge and experience with HS in dermatology, not just medicine, family medicine, and emergency medicine, is really bereft of experts. And so it's upon us, those that have had an interest, to spread the word. And I think the best place to start is at the universities in dermatology programs and get our new dermatology residents aware and comfortable with treatment so that we can offer hope on that first appointment. We know the diagnosis and we know that there's a plan for the future.
I feel like that's one of the most important things patients need, is just to know that there is hope and there are a lot of methods of management that they can try. It might take some time, but these doctors like yourself are so passionate about helping the patients that they're going to work very hard to get you to the place you need to be. And
I,
while
I,
talking about
I was
patients,
I have a question real quick.
Sure.
How did you feel about, the decision between you being able to prescribe the medication for patients with the non-medical switch being taken out of your hands? And have you found there's been a lack of trust in the community with patients that you have being switched over from a biosimilar or from a biologic to a biosimilar?
Sure, I'll answer that question. Let's backtrack for the audience. My approach to hidradenitis suppurativa includes 3 arms. There's first the team. We offer a place of safety, of comfort, of understanding at our clinic, and access that they can get during severe flares and for the long-term management. It's not a one-visit clinic. It's a chronic condition and there's no cure. So that's the first part of our engagement with our patients. And the second is that we have medical treatments for hidradenitis suppurativa and surgical treatments for hidradenitis. Historically, it was purely a medical treated condition thought to be infectious, now understood that it's an inflammatory condition associated with other inflammatory conditions and a general metabolic syndrome. So the importance of understanding that it's an inflammatory condition and choosing good anti-inflammatories is critical, as well as understanding that the consequence of these inflammatory regions is abscesses, carbuncles, furuncles, if you want, but multiple abscesses that make tracks that then fistula form contact to the outside skin and drain. Those then become surgical indications. The medicines aren't going to cure those tracks and fistulae, and certainly not the heaped up scarring we see as long-term consequences of those. So we have to understand as physicians that it's a multimodality treatment for these patients, and that if you don't offer surgery and good medicine, patients are not going to be well cared for. More specifically, we usually start patients medically on anti-inflammatory antibiotics. Any of the tetracyclines usually are first-line treatment and very effective. Topical antibiotics can be used to clear up some of the smell that is associated with it, but it really doesn't affect the inflammatory condition deep in the skin where the problem begins. If patients have significant disease, and we base Hurley stage 1, 2, and 3, where 1, they have a couple of papules in multiple locations, Hurley 2, where there's connected sinuses and abscesses, and Hurley 3, where you see some scarring and fistulae, those Hurley 2s and Hurley 3s sometimes require advanced treatments in the anti-inflammatory category, and that's where this word biologic comes up. So presently, the only biologic that is indicated for hidradenitis suppurativa is adalimumab. Now, Humira, the brand name for adalimumab that started the ball rolling really for all of what we're doing right now, AbbVie had a really invested approach to dermatology and HS and has really pushed this condition into the forefront. And they really need to be commended for that. But their drug, which has been around for years, treats Crohn's, treats rheumatoid arthritis, and treats psoriasis and psoriatic arthritis. So its time on the market has been over a decade. And once the patent runs out, anyone can come along and make the same medication. Now, there's this new group of medications called biosimilars. So we had our biologics like adalimumab, but there are biosimilars which are not exactly like adalimumab, but functionally have the same shapes and in trials have shown similar effects. Whether or not they are truly as effective, time will tell. We certainly see in the rheumatology and psoriasis literature, they're proving to be reasonable, but it's still up for debate in HS. But we don't have a choice. And so because of the cost of medicine, and these medications can run in the tens of thousands of dollars per year, each injection every other week can be as expensive as $1,000. And so we know that this is a component of the treatment of the disease, hidradenitis suppurativa, is good stewardship of healthcare dollars. If you only have one pimple in one armpit, you don't need to be on a biologic. On the other hand, there's a vast population of HS patients who had no treatment, let alone the biologics. But we've had really good results. About 60% of people who get on adalimumab under the old name Humira did great. And unfortunately, because of the government choosing to cut corners and cut costs as these new companies came on board making biosimilars, of which there's 5 or 6 for adalimumab, we really can't say what the data is. There's too many companies, too few patients who've been switched to come up with what I would say is good scientific evidence-based answers to your question. Have I had patients who were on adalimumab made by AbbVie under the name Humira, switched to a biolog or a biosimilar and lost efficacy? I have. And for those patients, we advocate to their insurance company or to Blue Cross or to the government, Alberta Health Services in my province, to get them back onto Humira. And if I could put every patient on Humira, I would, because I know it and I'm comfortable with it. The program that supports our patients in learning about the medicine, getting comfortable with injections of that medicine, and following up with problems, whether it be a side effect perceived or actually related to that drug, their program is really good. And so I like the AbbVie program with Humira. But we are bound by the world we live in. And as a single soldier, there's little I can do to reassure my patients other than we have it, let's go switch, we have to switch, and let's see how you do.
So time will tell.
That's right.
Yeah.
Now,
I
there
just
are
want
lots of
I just want
molecules.
patients to know that this wasn't your choice, right? It was
Well, of
taken out of
course.
your hands by the government. I've had a lot of, patients reach out to me recently and in tears because, they do have private insurance and it won't cover it now. And I tell them, this is very similar, but this isn't your doctor's choice. It's what has to happen, and you just need to switch over.
Yeah. We are hopeful that new molecules are in the pipeline of research. The interleukin-17s, for those that know about Humira adalimumab, it's an anti-TNF inhibitor and works great for inflammation, conditions of inflammation like psoriasis, rheumatoid arthritis, and Crohn's, and now HS. There are new molecules that have been effective in inflammatory conditions that are crossing over and having trials done on them. So secukinumab is coming out, something called Cosentyx. Doesn't have indication yet, but it's there and available. And in weeks to months, I expect that is an option for those 40% who try adalimumab and don't have success. We have a backup. And if people get switched off of Humira to a biosimilar and lose effectiveness, we'll have another option outside the same mechanism of action, which offers a good optimistic hope that there's another medical treatment for their condition. And there are other molecules that are coming down the pipeline that are in the early research. I was in Miami in October and had some optimistic information that there's multiple trials going on for HS-specific molecules of anti-inflammation.
Is that JAK inhibitors?
Those are the JAK inhibitors, yeah. Same that we use for atopic dermatitis and eczema.
Do you know why HS seems to be indicated last? Because, a lot of these medications you said have been on the market for a while, but they're indicated for other diseases. It just seems that HS is indicated last for a lot of these medications. Is that just, lack of funding, or HS is more complex?
No, it's simply awareness. Psoriasis, eczema, and alopecia areata, these have been conditions that enter the dermatologist's doorstep every day, multiple times a day. And so the awareness for these conditions has been decades. And there have been other medications that have been employed for those, specifically to those conditions. So pharma awareness has been high. I think if you look at hidradenitis as a condition, the interest in it is logarithmic. Things have gone skyrocketing across North America and Europe from a research point of view, from an interest point of view, but it's just late to the game because patients didn't get acknowledged. Their diagnosis wasn't made. So the information didn't track to the people with the money, which is pharma, until recently. And so late, it's not about the disease or anything about the disease that is shunned by pharma. It's that it is only now, over the last decade, been recognized universally as something that needs research and has avenues of effective treatments.
And it's coming. This morning I found an article in this month's Ebony magazine, which is and they had Dr. Angela Lamb, who's in the States, talking about HS. And that's, a pretty mainstream magazine to have a full, unpaid article on it.
Yeah. Well, we certainly see in African American patients a higher incidence of hidradenitis suppurativa. It doesn't diminish the importance in all skin types, how severe it can get, but we certainly see an increased incidence in darker skin.
What about in First Nation Indigenous folks? I know my GP told me that she was starting to see it run in families in some of her First Nations patients, and that she was really struggling to get them, to go into their referral. And are you seeing a lot in the community there as well, or?
I mean, Alberta has a large Indigenous population, and I see and have many patients who are Native Canadians who have HS. There's no studies to indicate their incidence compared to Southern Canadians, so I don't have any comments other than I have patients with it. They certainly run in families, but they run in families in all skin types.
Mhm.
So you're kind of known in Canada as one of like the big surgical HS guys, and you teach a lot of the dermatologists. When do you kind of decide that surgical intervention is needed? And how do you feel about like incision and drain? Is that still an effective tool for people to use, especially when they can't get in for a de-roofing right away?
Yeah. I'd like to tip my hat that I learned about the surgical approach to dermatology from Bill Danby, who was in the United States. He was from Toronto originally. So it was a Canadian that inspired me to get interested in the surgical aspect of hidradenitis. But Canadian-wide, Ralph George in Toronto, a general surgeon, has held the torch for 30 years in hidradenitis suppurativa. And I've had the good fortune of working side by side with him, seeing the evolution of the surgical technique for HS over the past decades, so that we now, similar in derm and in general surgery, we treat these patients the same way with the de-roofing or unroofing. Specifically, when do I do de-roofings? As soon as possible, period, full stop. If a patient comes to me and they point to a lesion that they've had on multiple occasions in a single spot, I believe it's an indication for de-roofing. Whether it's the size of the fingernail on your pinky finger, or whether it's a palm-sized lesion in the axilla or groin, they're all indications. When I meet people for the first time on consultation, it's an overwhelming visit. There's a lot of information that they need to hear. There's a lot of information that they want to share about their journey through HS, which has always been pretty negative. And so there's a period of time where we need to listen to our patients and hear how they've struggled with the condition, how they've struggled with healthcare, how they've struggled with pain, how they've struggled with intimacy, how they've struggled at work with this condition. So often on the first day, there's no surgical intervention offered, mostly because we've spent a lot of time just getting to know each other and establishing that there is hope for this condition and that they found a new home for their HS with us at Symmetry. But at that time, the first thing that I do is I go through our conservative approaches: smoking cessation, low dairy diet, supplementing with some vitamins, calcium, vitamin D, and zinc in some cases. Then I talk to them about the medications they've been on, the ones that I offer, what can we do for them as an individual, and arrange a 3-month follow-up to see if that first anti-inflammatory intervention makes a change. And then do a physical exam and see if there are any active lesions. If there's an active lesion at that time, certainly we have time for an injection, which is a part of the surgical approach to HS, where we inject a steroid and settle down small ones. If, however, they've got areas of recurrent lesions, we book them for a half hour so we have time to do the de-roofing properly. Get them frozen up slowly so it's not too painful. Medicate them with anti-anxiety medications for people who have needle phobias, and just give them a chance to absorb all the information we've delivered, anticipating a surgical procedure that is going to give them pain-free benefit to that location. That being said, every day I'll have a patient who comes in and I'll say, look, this is a small lesion, maybe the size of a loony or a toonie, and that it would benefit from de-roofing. If they're somebody that doesn't have a lot of anxiety and they're highly motivated to get their treatments going, they've been to other doctors, they're stalled with their treatment, and we introduce de-roofing as a solution, or they come knowing that I do de-roofings, we'll freeze it up and do it that day.
What about like a patient that doesn't have a derm yet? Like there was a article that came out that says say no to INDs. And if you don't have, a dermatologist and you get a big heater, in Beth's words, on the weekend, or is there a risk that you that can get infected if you don't go and get it lanced and get put on antibiotics? Like, I just know there's been times where I have wanted to take the kitchen knife myself and just jab it open because it would feel so much better getting the relief. So are there times when INDs are necessary just for instant relief?
Yeah. Incision and drainage for abscesses across the spectrum of medicine, because you can get an abscess that has nothing to do with hidradenitis suppurativa, and draining the abscess is first line treatment because it helps with pain relief, and it helps to eliminate the bulk of purulent material, which your immune system is going to take weeks to clear up. If you can eliminate that, you get the short-term benefit of pain relief, and you get the potential long-term benefit of it healing faster than if you had just waited for the lesion to resorb. Now, doing it with a kitchen knife at home is not recommended because you're now introducing bacteria that could become cellulitis, an infection. Rarely do I see a patient first with an abscess that I think antibiotics for infection are indicated. Like the treatment of HS with cephalexin or Keflex is done in all kinds of hospitals, but I don't think it's a bona fide treatment unless there is evidence of cellulitis. It's inflamed and hot and extending in a direction away from the original abscess. Then I will consider doing a antibiotic course for an infection. But in most cases, and I mean 99% of cases, an incision and drainage and a de-roofing are really close in the amount of time. So I don't do incision and drainage, but I know that that would be on the short term huge relief. Every HS patient I've ever met has gone to the bathtub and in a crisis cleaned the area and just squeezed until they expressed the painful full abscess. And who wouldn't do that? What I'm hoping that is clinics like ours open their minds to the idea that these patients do call in an emergent scenario and need to be seen within 24 to 72 hours to have something done. So yes, an incision and drainage is an effective treatment for pain, but it's not an effective long-term treatment for the abscess in HS.
And it has high reoccurrence. I just wanted to make sure that, sorry, Michael, that patients know that, if they don't have a derm and they are in pain, it is okay to go to the, ER and get this done, because, it's something that we all have had to do at one point. And yes, it's preferred to be able to get in and be with you, but if you're in a jam, I just want them to know that that is okay.
Yeah, there's just a high likelihood that that abscess after drainage is going to recur. So if you go in on a Saturday afternoon, have it incised and drained, and you have access to a physician who understands de-roofing, then by all means, get the incision and drainage, and then later on that next week, come back and have it addressed for its long-term surgical management.
Yeah.
It wasn't that quick in my case, but I know my last major lesion, I had to go in and get it lanced, but that same day they put in a request to Dr. George.
Right on.
Oh, and I saw him about a month later for a consultation. But yeah, it was immediate, short term, he's in agony. This thing is huge. Let's help him if we can, but we know that he's going to need more help.
Well, and
Absolutely.
again,
I support that approach.
yeah, and there's not, like de-roofing isn't something that isn't thrown on the table for everyone, right? So I don't want patients to feel like, oh, let's not go get an incision and drain and say no and then be in severe pain because, not everyone has access to be able to have a de-roofing. So I just wanted to get some clarification
Right.
on that.
Like my dermatologist who saw me that day wasn't the chief dermatologist, Dr. Gooderham. It was a newer one, a younger one, and she was not comfortable with that. So she called in actually another doctor in between the two of them. They lanced it, but she had also trained under Dr. George. So yeah, she knew, and it was very obvious I was going to need something down the line. But no, get it. It helped so much. I would have tried and gone to an ER if she had not lanced me there. I was in so much pain, and it did. Like within 24 hours, the pressure was significantly better. Like, yeah.
And if the option isn't available, that's when people turn to, at-home tools and try to do it themselves,
Right.
which is in itself quite dangerous.
I'm lucky. Like the heater, as Crystal called it, for me, it appeared on like a holiday Friday, if I remember right. And I was in tears the phone Monday morning. They got me in Monday afternoon. I'm really fortunate that my derm could do that. But yeah, no, by all means, I would say get that done. If that is an option, you can't see someone right away for sure.
Is there a patient for you, Dr. Keeling, that stands out as being the most memorable? Don't say Crystal, because she's on the call.
I would say Crystal's probably been my most influential patient. Most memorable? Yeah, absolutely. I've seen disasters from a surgical point of view. I've seen disasters from a medical point of view. But the most rewarding case is a patient who came to me with a long-standing history of HS, undiagnosed by her family doctor, hidden away for decades, dealing with it on her own and from time to time in emergency, who responded very well to oral antibiotics, transitioned to the biologic adalimumab, and was treated for isolated lesions with deroofing and debridement. And within 6 months was at a state where she was managed only on smoking cessation and low dairy diet, had come off all of her medications, was getting no new lesions, and came in and said, I have my first boyfriend at 32. If that doesn't bring a tear to your eyes, I don't know why you're in medicine. But it was the most rewarding thing that I've ever seen, is that the interventions with medicine, surgery, place that they could call home, and she developed completely as a woman. She found her place in society and was happy, and that made me very happy.
I feel like
Nice story.
something we see with uh, especially the derms who treat HS in Canada is they really are treating the patient, not the disease. They really take we like the word holistic approach to the disease management, and it's just such a game changer when we finally find one of you and end up in your care, because it's just we suffer for so long, and then it's just a total 180, and we're able to live our lives happily and without pain.
Yeah, I've had some success stories where patients came in and they were carrying extra weight. And after the diagnosis, after the management was established and they were seeing success, I've had people shed 100 pounds. I mean, I don't know how anyone can lose that much weight. But with HS, you can understand why exercise and routines and diets are impossible to maintain because of how badly you feel physically and emotionally. And when we see patients who get on the good side of treatment, their heroic spirit comes to the forefront, and they just start changing their lives, and they get out exercising, from walking to the gym to regular dieting, and then almost disappear. I've seen people with over 100 pounds from the beginning meeting them to now 10 years later, just champions in my mind.
It's like all that energy that was spent just trying to survive can then be used, in more productive areas. And it's just incredible.
Absolutely.
There was a study that was presented on at the SHSA conference about diet. I think it was done in the Netherlands, but I want to say the gist of it was that it really only helped patients in like mild stages or early stage 1 because they were still able to physically, go to the grocery store and kind of maintain and make the meals, whereas they didn't really address patients in like late stage HS who, maybe can't move or stand or do really much of anything because they're in so much pain and the disease is so extensive.
Or afford to be able to eat like that. It's expensive to, these days to be able to eat healthy.
And it's so understandable why people with late stage HS do carry more weight because healthy options are not easy to make and the unhealthy options are quick and available. So you're not moving, you're eating quick and easy meals, and then you just gain weight. And also that can help the disease progress. And it's just a vicious cycle for people in late stages if they don't find somebody who can help them manage it.
I completely agree.
We have some patient questions that were sent in. So the first one was, can HS be passed from person to person?
So the idea that HS is an infectious disease or it's contagious is untrue. There are bacteria there, but we have bacteria on us all over the place. The ones that are inside the abscess in HS are fantastic if you're a taxonomist or an infectious disease doctor, but they really aren't an infectious process of the skin instead of a contamination of the dermis. So specifically saying, no, you can't pass on HS, but we do see it runs in families, and we can have 3 generations in my office at one time where a grandmother, mother, and a daughter all have varying stages of HS. And so the genetic component, which isn't entirely worked out, is definitely there. So you can pass it on to your progeny, but you can't pass it on to a partner.
So you're not going to get HS from a toilet seat.
No.
Okay, the next question is, do you have any tips for odor control?
Yes. Good medical surgical management. The best way to treat the odor is to fix the problem. In my mind, it's with the conservative modalities, along with the medical modalities, along with the surgical modalities. That being said, are there things you can do? Absolutely. These are filled often with gram-negative organisms, and some topicals are beneficial. We use clindamycin commonly in my clinic. Metronidazole, which is a gel that we use for a condition called rosacea. It also can work to help with the gram-negative organisms that are in the region. I don't push anything more than just regular soap and water, because I know that eventually I'm going to get them on an antibiotic, perhaps a biologic, and then operate on any of the recurrent abscesses, which in my mind never benefit with topical or oral antibiotics or anti-inflammatories.
What about things like Head and Shoulders shampoo or a Nizoral shampoo? I've been told by a few different derms that they would be a body wash, not for hair, but for your body. Are those, effective, or do you find they don't make a difference?
I have never advocated those agents. I know that one of the plastic surgeons in Toronto advocated on top of zinc, selenium, but that was orally. So selenium sulfide in dandruff shampoos, I don't know how that would benefit. In my mind, all of those agents you just mentioned in the shampoos, they treat yeast. And so HS isn't an infection and it isn't a yeast complication. So I don't see the mechanism of action. But if there's a study out there that I'm unaware of where patients have seen improvement with shampoos, I'd be curious.
What about bleach baths? I've seen a lot of like TikToks where patients have HS and they're suggesting to other patients to have bleach baths. So I was just wondering, what's your view on that?
I recommend bleach baths in atopic dermatitis or baby eczema, where you take a cap, not cup, a cap full of bleach in a bath, so that it smells like a pool. And the reason pools smell like pools is to reduce bacteria load. So we know that in eczema, those lesions, when they become crusted, get contaminated with bacteria. And using a immunological process called superantigen drive can make the eczema unresponsive to traditional topical treatments. And so bleach baths in crusted, if you want to know if you have scabby eczema, I certainly recommend bleach bath. You have to be careful though, because it's bleach and you can irritate the skin and cause an irritant contact dermatitis. So a poor dosing of the bleach in the bath would be unadvisable. Back to HS, there are certainly bacteria around, but even if you eliminated all the bacteria on the surface of the skin with the bleach, you're really not taking care of the inflammatory condition that starts the disease, and you're not taking care of the deep bacteria that are causing the inflammation in the skin in an abscess, a sinus, or a fistula. So yeah, bleach baths probably help with odor, but in the end, solve the problem. You can put a Band-Aid on a tire, but change the tire. If it's got a flat, you gotta fix the tire.
Okay, the next question is, do you have any advice on skin thinning or people who have concerns about skin tears after they maybe heal from a large open wound?
Yeah, it happens all the time. There's no topical agents other than the silicone gels, which benefit scarring, that have any evidence to support that, and none in the HS community. So I don't have any, I'm not speaking from HS research. What I find though is that if you're incising and draining multiple times lesions, the skin over top is on an inflammatory bed and doesn't create a thick dermis underneath. So my experience is that by de-roofing it, having a good granulated base and then epidermis growing over a healthy base, that epidermis is intact and isn't thin. And so again, I fall back to, we're looking for a treatment of a problem, thin skin, while waiting for a proper treatment, which is de-roofing in my mind.
When I used to get HS very extensively under my breasts, and after it would heal, the skin appeared to be so thin, like you could see the veins really clearly underneath it. And I was always very scared that, if there was too much rubbing or friction, it would somehow cause a tear in the skin, but it never did. And I feel like over time it has actually thickened and I no longer have that worry.
Remember, when a wound is healing, you have angiogenesis, the arrival of new blood vessels that bring oxygen and nutrients to the wound. So all wounds or areas of healing are going to be more red and appear thinner until the skin and the fibroblasts make the collagen that makes the dermis, that makes it thick, that makes it protected. So early on in the process, absolutely it will be thin, but you need to let Mother Nature do her job. And that's probably you're experiencing things going well, because you did protect it. You were naturally careful, not wearing an underwire bra and going and running a marathon. That's going to probably have led to an issue.
Well, I'm chubby, so I probably wouldn't have run a marathon anyways.
Yeah, I would have a hard time too. I could fall out of an airplane and run a marathon as long as it was down vertical.
All right, our last question is, are there certain types of birth control that can cause HS to flare? And do you find that it occasionally improves after the discontinuation of birth controls?
I learned from Bill Danby to add estrogen to the treatment, but I'm learning now that there's a particular group of HS patients that have responsiveness to estrogen. The phenotype or the expression of HS is varied. We still haven't defined it formally yet, but most of us that are involved in HS treatment recognize that there's a follicular type, a type that it's almost always around little hair follicles and looks like folliculitis. They're not big abscesses, they're small little zits, if you will. Looks like back acne or bacne. They often are associated with facial and back acne, and that phenotype is an example of one type. So there's also a type that are like polycystic ovarian syndrome, where they have extra weight, they have irregular or heavy menstrual, perhaps hirsutism, deepening of the voice, more hair in the genital areas. And these women do benefit from multi-modality PCOS-like treatments, which help with their HS. So we'll put them on estrogen and perhaps an androgen blocker like cyproterone, the old school Diane 35 birth control pill, has the two agents in it. I'll also put them on an antihypertensive medicine called spironolactone or aldactone. That has anti-androgen properties, which benefits the PCOS patient group who have HS. This subtype of the HS patients who have that particular phenotype. And then I'll use metformin, which is also a anti-diabetic medication, but has some anti-androgen boy hormone benefits. And the combination of the three hormone blocking potential seems to benefit a small subset of HS patients. Which ones get worse on estrogen? I haven't seen that population, but I mean, the hormones is a black box for me as a dermatologist. I didn't get excellent training on the components of hormones and its effects to then translate it to HS. So I think that's an area of study that's still in front of us.
And what about progesterone-based birth controls? Do you find that people flare more when they use those? I found I flared a lot more, and I think they spoke about it at the conference in Miami about how they maybe make people flare more.
They did mention that, and I haven't seen that because I don't prescribe progesterone birth controls. And I think that is in the hands of the family doctor and OBGYNs. Perhaps I need to spend some time with that group, learning more about their hormonal treatments. But they're also a group that is genuinely in the dark about HS, despite having, you know, their entire focus in females in that area. I have found that they are in the camp with family doctors, emergency physicians, and we can shed some light on HS with that group, and then benefit from their knowledge of things like hormonal treatments and the risks and benefits for our HS population.
And like, is blood clots are a indication for estrogen-based birth controls?
It's a relative contraindication, absolutely. The patient that I avoid estrogen in is the over 35 and the smoker. And if they've had a history of a pulmonary or leg clot, then I would be reluctant to give them a birth control pill for HS when we have other options for them. The select group of hormone treated HS is a small part of my practice.
Well, I think we've come to the end of our discussion. Michael or Crystal, do you guys have any last questions for Dr. Keeling? No, Dr. Keeling, do you have any closing remarks you'd like to make for the HS community who's watching or listening?
There's hope. This is an area of medicine with growth, increasing interest. We're at the nascent stage where there's pockets of us that have developed an interest. I certainly didn't go into dermatology because I thought, I'm going to be a champion for HS. HS came to me through an association with Bill Danby, and then through collaborations with AbbVie and their medication adalimumab, sponsoring talks, sponsoring research, sponsoring collaboration between specialties. This is the birth of a awareness in HS. So I think the future is really bright. I've watched psoriasis since my training in 2000 become a disease that's easily managed with our biologics. And that is a condition that's had research on it for decades. And over the last 20 years, psoriasis and psoriatic arthritis are really less challenging. We're seeing the same thing with atopic dermatitis and the biologics, we're really getting on top of the severe cases of that. So if HS follows those more historic dermatologic conditions with the support from our pharma colleagues, I don't see any reason that we couldn't look forward to an era of significant improvement in our population.
Righty. Thank you, everyone, for joining us today. And thank you so much, Dr. Keeling, for the valuable information you gave us and the care you provide to HS patients. Join us next month for another episode of the HS Heroes podcast. And until then, remember, real heroes don't wear capes.